All right, so for this next exam, we'll be talking about the skin, the bones, and joints. So let's start by talking about skin. The skin is the major part of the integumentary system, which also will include the hair, the nails, and the various glands associated with the skin. It's the largest organ of your body. It makes up about 15% of your body weight. Now, there are two layers of tissues here. There is the epidermis, which is the outer layer. Here, oh, sorry. And then there's the dermis, the deeper layer underneath that. So the epidermis out here, the dermis here. Now, if you look, the epidermis out here, there's no blood vessels going through it. We look really closely, oops, just a bunch of cells. So the epidermis is epithelial tissue. In fact, it's stratified squamous epithelial tissue. The dermis is connective tissue proper. So often we talk about thick or thin skin. Thick skin is found on the palms of the hands and the soles of the feet. The added thickness is due to an extra layer of dead cells out here, the stratum corneum. In thick skin, we find sweat glands, but we don't find hair follicles or oil glands. The rest of the body, we still have the stratum corneum, but it's much thinner. And it's associated with hair follicles and oil glands. So what's the function here? The skin's a big barrier. It keeps stuff out and keeps stuff in. It's also one part of making vitamin D. Lots of nerve endings there. And it's part of thermal regulation and how we recognize each other. Let's start by looking at the outer layer of the skin, the epidermis. In the epidermis, we find 5 different types of cells. It's epithelial tissue, so we're going to find stem cells, where that epithelial tissue is always regenerating. These stem cells are continually dividing. We have keratinocytes. Most of the cells are these living keratinocytes out here. Melanocytes down here in this basal layer. They're the dark colored cells through here that make melanin. Tactile cells are touch receptors, and you can see they're connected to a nerve ending there. Dendritic cells are macrophages, and this is part of your immune system. Helps guard against pathogens. Now, these 5 different cells of the epidermis are found in 5 possible layers. The basal layer is called the stratum basale. Here we see melanocytes, stem cells, and these tactile cells. Above that, the stratum spinosum, or the spiny layer. We have lots of keratinocytes and then some of these macrophages through here. Above this spiny layer, we get into this layer here that's called the stratum granulosum, the granular layer. 3, maybe 5 layers of keratinocytes. Inside, we see keratohyalin granules. All right, so these keratohyalin granules, these are protein granules made up of keratin and some other proteins that are going to contribute to the process of keratinization. As we get here, those granules are going to release their contents, and the cell is going to keratinize. Basically, everything that is in the cell becomes keratin. Stratum lucidum is the layer just above that. So this is the translucent layer. It's really only visible in thicker skin. And here is sort of the junction in between that stratum granulosum and the outer layer of the skin. Here in the stratum lucidum, we have elidin, which is a clear protein, and it's sort of the intermittent or intermediate phase between this keratohyalin and actual keratin out here. The stratum corneum, this outer layer, up to 30 layers of dead, fully keratinized cells that form the surface of the skin. So again, keratinized means the cytoskeleton and everything that was inside the cell is now this sort of durable protein, keratin. As keratinocytes multiply, they push up so that the older cells are pushed away from the body here. Newer cells are down toward the basal layer. Older cells up here at the stratum corneum. There you see this term exfoliation. The dead cells that have keratinized, they've died, they've keratinized, they fall off. And that process is called exfoliation. In that stratum granulosum, they're dyed. That's where they undergo apoptosis. And those keratohyalin granules rupture, and then we go through this process of going into elidin and then keratin. The dead keratinocytes exfoliate or fall off, and the particles of skin are called dander. If that clumps with oil or some other substance and it clumps together into big chunks, we call it dandruff. So here you see this ad from the 50s about dandruff, which they used to think was some sort of infection. It's not, it's just a clumped up skin. But in this process of exfoliation, you have to imagine that there are lots of us, and we have lots of skin, meaning that there are lots of dead cells falling off. Those dead skin cells you will see in your house all over everything. When you are dusting your house, that's what you're dusting off the furniture. It's you. Now, I'm sure there's some dirt, but dirt is little tiny bits of rock. Dust in your house is little tiny bits of you, or people you have in your house, or dust will form. But these are keratinized cells, so that's a protein. That's a resource for something, and it actually creates its own little ecosystem. The proteins in those cells support mold and bacteria and mites, like the household dust mite here. They're metaphagoides. You find it anywhere you find dead skin. They're fairly ubiquitous, meaning that they're everywhere. To illustrate that idea, you'll notice that it's missing something, but it doesn't have any eyes, because they're that ubiquitous. It doesn't need to look to find a food source, because again, we're pretty much everywhere. It doesn't need to look to find a mate, because they're pretty much everywhere. They're over anything that where you can find dead skin cells, and they're going to be the highest number in your house in things that are made of fabric. So mattresses and pillows will be the worst. You're rubbing your face on those, and the skin cells are exfoliating off. Carpet, stuff like this. Um, you can right now run out and bleach your world, and you'll reduce their numbers, but you're really not going to ever exterminate them completely. But better than this is Demodex follicularum, or the eyelash mite. The eyelash mite feeds on the dead skin that clumps around the hair follicle and oil that builds up in the oil gland associated with the hair follicle. Now, typically, these don't present much of a problem. They're not parasitic because they're not taking anything from you, but they're not symbiotic either. They're not helping you out. They just live on you. Commensal organisms, if you will. Now, if enough of them are around the base of the eyelash there, you will see some inflammation as your immune system doesn't appreciate a large number of those mites. When I taught microbiology at Tech, we looked for eyelash mites, and I had students pull out their eyelashes and throw them under microscopes so we see if we had eyelash mites. It took a while before we found some. Somebody eventually had like one or two. Mostly it was just to see if I could get students to pull their eyelashes out, and that was hilarious. It's a microscopic thing. You will need a microscope to see it. It only lives on your skin. And most people do have them at some point. You don't find them on babies, but typically they show up shortly after birth. By the time you're old, there's going to be a ton of them. But again, typically not associated with any issues until they get to a large degree of infestation. You have your own ecosystem here, right? You've got yeast, the bacteria, and they're kind of in a turf war on your skin. Typically, they keep each other in check as they sort of fight this out. If one or the other replicates out of control, then we get inflammation of the skin, and we have yeast infections of the skin or bacterial infections of the skin, where one or the other organism infects the skin. The skin is a barrier, and it's resistant to most of these microorganisms, but it is weakened by continual moisture. Keep that moisture right up next to the skin, and it provides a breeding ground where microorganisms can replicate and then irritate or even infect the skin. Now, that's all on the epidermis. Deep to the epidermis, and we see the epidermis here in this sort of lighter purple and the clear area out there. This darker purple through here, this is the dermis. It's connective tissue proper. Collagen fibers, some elastic fibers and reticular fibers, but mostly the stuff we would associate with connective tissue proper, things like fibroblast. Unlike the epidermis out here, the dermis is vascular. There are blood vessels. The hair root follicle, the nail root, is embedded in the dermis. Sweat glands and oil glands, and nerve endings. Every little hair follicle has a muscle called the piloerector muscle to make your hair stand on end. The dermis and the epidermis have this wavy boundary. The upward projections of the dermis here are called dermal papillae. The downward projections of the epidermis here are called epidermal ridges. They sort of lock the two layers together so that they don't separate. The dermis really has two layers. We can kind of see it here, this lighter purple region that makes those dermal papillae. Those are it's the papillary layer. This is loose areolar tissue, tons of blood vessels. The reticular layer is the deeper layer here. This is dense, irregular connective tissue. Not as many blood vessels, so lots of collagen fibers sort of haphazardly through here. Stretching that deeper layer can tear the collagen fibers, and this will heal through fibrosis, produces striations or stretch marks. Under the skin is the hypodermis. The hypodermis is not skin. It's under the skin. Sometimes this is called subcutaneous or superficial fascia. Its job is to hold the skin to the tissue underneath. Lots of blood vessels here. Subcutaneous fat is hypodermis. We talk about this because hypodermis, you'll notice, is very similar to the term hypodermic, which is a type of needle we use. A hypodermic needle is the shorter needle, and it is just long enough to inject into this region. So you make an injection into the hypodermis, it's very vascular, and that's going to be picked up by the blood very quickly. Skin, obviously, we've got different pigments of skin, and this comes from melanin. Melanin is made by melanocytes, and there are two forms of melanin: eumelanin, which is kind of a brownish color, and pheomelanin, which is kind of a reddish yellow color. The neat thing is that all people basically have the same number of melanocytes. The difference is in how much melanin they produce. Now, genetically, there is a propensity of cells to make more or less melanin. This is inherited from your parents and from their parents and so on. But in addition to that, melanocytes can be stimulated to make more melanin. The amount of melanin made by melanocytes will vary with the amount of ultraviolet light your skin is exposed to. Ultraviolet light stimulates melanin production because melanin is a photoprotectant. Melanin is released when cells of your skin are damaged by that ultraviolet light. Ultraviolet light is ionizing radiation. It damages the DNA of the cells, and the body responds by producing more melanin. Now, it's important to notice that that's not a preemptive strike. Your body doesn't produce melanin in anticipation of damage. It produces it as a result of damage, hoping that the next time the damage is not as severe. Other things we can see in the skin in terms of pigment: hemoglobin is the red pigment in blood. Subcutaneous blood vessels, when they dilate, you can see the color of blood through the skin, provides sort of a pinkish color. Carotene is a yellow pigment that's in things like carrots and yellow vegetables. It can be concentrated in the stratum corneum as well, and it kind of creates an orangish color to the skin. If you attempt the all carrot diet, don't do that. It will turn you orange. We can diagnose things from the skin. Cyanosis is the blueness of the skin. We see when there's a lack of oxygen in circulating blood. It's often seen in children that have congenital heart defects. This is a cyanotic heart defect, so that low oxygen blood is circulating out to the body. Erythema is an abnormal redness of the skin that's caused by increased blood flow. Now, this can be temporary, like blushing, or this can be a little longer lasting, like sunburn. The capillaries are abnormally permeable and the blood cells are cooled. Pallor is the color of people that are dead, or if you've ever seen anybody that's about to pass out and they just kind of go really pale, that's pallor. Sort of a gray ashy color. Basically, there's so little blood flow to the skin that you can see the color of that dermal collagen. It's kind of a white gray color. Albinism is the lack of melanin completely. This is a autosomal recessive gene, and people who have albinism have two copies of the gene and they don't make any melanin. So their hair is white, their skin is white. Their eyes look pink. Now their eyes aren't actually pink. There's no pigment in their eyes. And that pink color you often see is the color of the retina. Just like when you take a picture of someone and you get that red eye effect where their eyes look red, you've taken a picture of the retina, the light's bounced off the back of their eye. People that are albinos, they don't have any pigment there, and so their eyes often look pink. This leaves them susceptible to damage from ultraviolet light to the eyes, to the skin. Jaundice is a yellowing of the skin. It's caused by a buildup of a pigment called bilirubin. In an adult, jaundice indicates something wrong with the liver. Often you'll see this in newborns, and it just means the liver hasn't quite kicked in to do its job yet. In an adult, this is a serious issue because it means your liver is not doing its job. You can see here, even the whites of her eyes are yellowed. This is a hematoma, clotted blood that shows through the skin. It's been a while since I found this picture, and I can't remember what it was. I want to say this dude got hit in the leg with a baseball bat. So yeah, that's a giant bruise. This is argyria. Argyria is this blue skin tone that's caused by stupidity. All right, so what happens? Colloidal silver. Silver has a colloid in water. So you have silver ions that are suspended in water with the idea that silver is slightly antimicrobial, which it is. It's slightly antimicrobial. That does not mean that it's an antibiotic. Bacteria don't really dig that. Well, off and on, you'll see people who ingest colloidal silver. And in small amounts, there's probably no real harm here. But in larger amounts, that silver will begin to build up in your system, and it will deposit in the skin, in the dermis. Well, if you've ever owned anything made out of silver, or if you're familiar with the way that photographs work, incidentally, photographs. We used to have this stuff called film, and you'd take pictures with a camera, it would expose the film to light, and then you'd have pictures developed. I know, it's weird. But if you're familiar with that process, the way it worked was it exposed that film to light, and one of the chemical reactions that happened here was involving silver. You expose silver to light, it changes color. If you have anything made out of silver, it tarnishes, right? Well, now you have all these ions, and the silver is sort of deposited in the skin. When you go out in the light, it changes color. And you get Papa Smurf. She's super sad because she's blue. You're welcome. This is permanent. They've tattooed themselves blue from the inside out. One of the better publicized cases was a guy that was running for Senate. And they had like a debate or a town hall meeting or something, and the press corps kind of freaked out because he just kind of turned gray, kind of a blue-gray. They thought he was having a cardiac event. They thought it was hypoxic or cyanotic. And it turned out that it was just this argyria thing setting in, that he'd been doing this colloidal silver bit. So if you're doing this, I would advise that you don't, because, blue, or at the very least that you back it off some. Incidentally, there's really no benefit to drinking or bathing in or applying colloidal silver. We have better stuff than silver to kill bacteria. All right, so here, hair follicle, here, sebaceous gland. They secrete oil. It's associated with the hair follicle, lubricates the hair, keeps it from being brittle, that sort of thing. Sweat glands are pseudodiferous glands. We have apocrine and eccrine glands. apocrine sweat glands, excuse me, aren't actually apocrine glands. They're really American glands. I don't know why they call them apocrine sweat glands. They secrete kind of a thick sweat. It's not used in cleaning the body. It's usually what you'd associate with body odor. No, don't really care. Apocrine sweat glands are the smaller ones that are distributed all over the body that release water, salt, and some electrolytes on the skin. This evaporates and cools you off. The purpose of sweating is to cool you off. So, side note, sweating is not a means of detoxification. While you might find small amounts of urea in sweat, typically not so much. It's water and electrolytes. I'm not sure why the idea of sweating to detoxify ever came from. That's really not how that works. Detoxification is more of a job for the liver and the kidneys. If you're super drunk, you might be able to smell that alcohol as it evaporates, if you will, transpires from the blood out, but that's not detoxification by any means. So what I'm saying is you're not going to sweat out toxins. That's not how that works. Mammary glands, cereminous glands, which make earwax, they're sort of modified sweat glands. Now, if you're going into medicine, dermatology is a very competitive field of medicine, if not the most competitive field for medicine. Dermatology programs are hard to get into, super competitive. And I would imagine that some of that is job security. Pretty much everyone above the age of 60 has some medical complaint about the skin. And that's always going to be there. You're always going to have people that have skin issues. We have all sorts of issues, everything from acne to fungal infections of the skin, tinea. Incidentally, I will mention this. Ringworm, athlete's foot, jock itch, whatever, these are fungal infections of the skin. The ringworm, again, is not a worm. It is a fungus. If you have this, tinactin, done. I say this sort of as a public service announcement because the first semester I taught, we were going over this. I did have a guy that was very confused by this statement. And it suddenly dawned on him that the reason that he was unable to find the worm when he tried to cut it out was because it didn't exist. He didn't have a nice scar on his arm where he tried to hack out the worm from ringworm. Don't do that. So let's look at a few of these disorders. Acne, right? When the sebaceous gland ducts are clogged, and then bacteria kicks in, and your immune system fights that, and you get the inflammation, the pustules. Psoriasis is an autoimmune issue. It's a complicated process, and causes the overproduction of skin cells, inflammation, itchiness. In patients with psoriasis, this is not just a rash. If we could look closer, you would see that the exfoliation here is happening before the cells have completely gone through that process. So in psoriasis, the dead skin cells come off in these big sort of scales or flakes. They're still connected to each other. They're not coming off in individual cells. They're coming off in still sheets. Then we have skin cancer. Different forms of skin cancer. This is a basal cell carcinoma. Strata basale, it's the least dangerous form of this, and it's the most common form of skin cancer. It usually presents as a raised smooth bump. Someplace it's exposed to sun more often. It's rare to see it metastasize, but it can metastasize, don't get me wrong. They estimate somewhere around 800,000 new cases every year in the United States, and about 30% of Caucasians will have a basal cell carcinoma sometime in their lifetime. Personally, I have one of these on my wrist. Unfortunately, it sits right above a tendon that goes to my hand, and my doctor wants to do a removal of that with a punch biopsy, which is a full thickness cut. And I'm just not digging that above that tendon, so we're just gonna watch and see what happens. More likely than not, it's just gonna maintain. Now, a squamous cell carcinoma comes from the shadow spinosum. These are keratinocytes, so we're in an upper layer here. And prognosis here is pretty good if it's caught and treated. Usually it presents like this, where you have an ulceration or a sore that's open, these hard raised edges on the outside. It's slow growing, but again, it's not uncommon to see metastasis here. The thing here is that not only is this caused by sun damage, but also caused by use of tobacco or even HPV infection. Finally, we have the most dangerous form of this. This is the malignant melanoma. It will metastasize very quickly and it will kill you. 75% of people who die of skin cancer will die of a melanoma. Now you're looking at all the little spots on your arm right now, wondering if that's cancer or not. Looking it up on WebMD really fast. You've got cancer.com. I don't know if that's a thing or not, but it should be. So the rule here is it asymmetrical, right? Like that, that's super asymmetrical. An irregular border, that one, you see this irregular border, right? It's not just like a circle like that. It's this weird wonky border. Multiple colors, right? We see multiple coloration through there, here. Bigger than 6 millimeters, right? 1, 2, 3, 4, 5, 6. So these are millimeters, each little line's a millimeter. And is it enlarging, right? If yesterday it was, the size of a pinhead and today it's the size of a quarter, that's a problem. These are typically caused by UV light exposure. The more ultraviolet light you're exposed to, the higher your risk of developing melanoma. Today we know that purposely exposing yourself to ultraviolet light, i.e. tanning beds, causes melanomas. They are known human carcinogens, like smoking, exposure to asbestos and mustard gas in case you're in World War I, radioactive waste. Women of any age who visit a tanning bed once a month increase their risk of malignant melanoma by 55%. Do that before the age of 30, and it increases your risk by 75%. That's some good odds. Bad odds? Good odds for the cancer, bad odds for you. So most states have enacted laws that prohibit you from tanning more often than what they consider to be safe. Age limits so that you're not tanning. You don't have like a 12-year-old in there, super tan. Constantly exposing your skin to UV light, it's going to, yes, it darkens the skin color, but it's also going to cause wrinkles and age spots as you get older. Here's a really famous case that showed up several years ago. If you're wondering, you should Google tanning mom. So there you have this little girl and her mom. Yeah, right. That's her mom. It's not like a catcher's mitt that can talk. Her mom has got some psychological issues where she is sort of obsessive, compulsive tanning. And she's been banned from I don't remember how many tan salons, and like spends her days going from salon to salon to salon, just getting a darker and darker tan. And she got in trouble because she let her little redhead daughter participate and sit in a tanning bed and tan for a little while, like at 6 years old or whatever, which is obviously bad. Don't do that. Now what's going to happen is over time this is going to add up. Sort of the classic textbook picture is this one of this Native American woman who was in her mid-60s when the photo was taken, and this Tibetan monk who was in the mid-80s. The difference here is photoaging. She's never apparently been inside a building, and that degree of sun aging dries the skin and it prematurely wrinkles the skin. The less ultraviolet light you're exposed to, the slower that photoaging process occurs. One of the other major concerns we have with the skin is burning. Burns are one of the leading causes of accidental death in the United States, and death here will occur from fluid loss or infection, or just the flat-out toxic effect of the burned tissue. A first-degree burn is just involving the outer layer, just the epidermis. Now remember, the epidermis regenerates, so it's going to grow back anyway. Those cells are going to die off. There's nerve endings there, so it still hurts, it sucks, but it's going to be fine. A second-degree burn is still a partial thickness burn, but it's going to involve the epidermis and part of the dermis. This is when you see the blistering or sort of white tan areas through there. Still painful, but again, you might see scarring here depending on the thickness of the burn, the area that's burned, but this epidermis will regenerate. A third-degree burn is this full thickness burn. The epidermis, the dermis, and even some of the underlying tissue, the hypodermis, is destroyed. Now, in this case, that epidermis has nowhere to go, right? There's nothing to regenerate. So what do? Well, we do a skin graft. Take skin from one place and we move it to another place to bridge the gap. Now, first, that dead tissue has to be removed. That's debridement. You gotta remove that dead tissue. And then you graft skin through here. And the new skin provides sort of a scaffold for the patient's skin to grow to so that that tissue can repair and regenerate. All right, so that wraps things up